Welcome back to the deep dive. We're shifting gears today.
Yeah, usually we're wading through piles of research papers or debating the latest editorials, but it's a bit different.
Right. Today we are cutting straight to the chase. We've got a stack of high-yield oculoplastic revision notes, surgical protocols, classification systems right in front of us.
And just to be clear, this is strictly for the residents, the registrars, anyone really sweating over their upcoming boards. We're talking FRCS style.
Strict definitions.
Exactly. No fluff at all.
Yeah, our mission today is to essentially build the ultimate cheat sheet for you. We're hitting Ptosis, etropion, entropion, and globe procedures. We want to simulate that rapid-fire oral board environment.
Which is intense. You have to have these algorithms locked down.
Completely. But before we open the first case file, I have a quick request. If you are using this to cram, just hit follow right now. You really don't want to miss the retina or glaucoma revision sessions we've got coming down the pipe.
And hey, if we drop a pearl today that saves you in the exam, leave us a rating. It helps more than you know. Also, if there's a specific topic that keeps you up at night, drop it in the comments. We read all of them.
Yeah, we do. Oh, and one quick housekeeping note. We are covering the what and the how today. The algorithms you need to memorize.
The raw facts.
Right. If you want the why, the deep dives into the journal clubs where we debate the evidence or the specific clinical case breakdowns where we argue about management, you need to grab a premium subscription.
Yeah, that is where we get into the weeds of clinical decision-making.
Exactly. But for today, let's get you past topic 1, ptosis.
The absolute bread and butter of oculoplastics.
Let's start with the trap. The examiner asks you for a definition of ptosis or blepharoptosis. If you just say droopy eyelid,
You've already lost points.
right, we need precision.
You need metrics. You're defining it as the drooping of the upper eyelid below its normal position, but you have to define normal for them. In primary gaze, that upper lid should cover exactly 1 to 3 millimeters of the upper cornea.
And strictly regarding function.
Normal levator excursion, so that's the range of motion, is 12 to 15 millimeters. Anything less than that is flagged.
And don't forget the backup generator?
Right, Miller's muscle. It contributes that extra 1 to 2 millimeters of your fight or flight elevation.
Okay, so a classic board scenario is what I call the imposter. You walk in, the patient looks aptotic, but the measurements just don't add up. We're talking pseudoptosis. What is on your differential checklist here?
Well, you have to rule these out before you even think about touching a knife. You're looking for things like microphthalmos or enophthalmos. I mean, if the eye sits too far back in the orbit, the lid just lacks support and it looks low.
Right.
Conversely, if there's contralateral lid retraction, say from thyroid eye disease, the normal eye looks droopy by comparison.
Yeah, and simpler things too, like excess skin, dermatocallusis physically hanging over the lash line.
Exactly.
Okay, let's organize the chaos a bit. Classification. Residents love mnemonics, and for aposis, the gold standard is MMAN. Walk us through the breakdown.
Sure. MMAN. The first M is myogenic. That's muscle failure. So think congenital levator dystrophy, myasthenia gravis, or PEO.
Progressive external ophthalmoplegia.
You got it.
The second M.
Mechanical.
Yeah.
Physics is basically the enemy here. Gravity, you might have a heavy tumor on the lid, massive dermatocallusis, heavy scarring, or even it's almost just dragging the lid down.
Then we hit A, which is probably the most common surgical category we see.
Aponeurotic. This is purely wear and tear. A dehiscence or a disinsertion of the levator aponeurosis itself. It's usually involutional, so age-related, but it can definitely be postoperative too.
And finally, N.
Neurogenic. This is where the scary stuff lives. Third nerve palsy, aberrant regeneration, and 2 specific exam-favored conditions, Marcus-Gunn jaw winking and Horner's syndrome.
Let's actually pause on those two because they always come up as spot diagnosis questions. Marcus-Gunn, what are we looking for?
It's a synkinetic miswiring. It's congenital. Basically, you see the eyelid wink or flutter, specifically when the patient moves their jaw or nurses if it's a baby. The pterygoid muscle nerve fibers have essentially crossed wires with the levator.
And Horner's. You need the full tetrad to get full marks on the boards.
Right. Ptosis, meiosis, which is the constricted pupil, and hydrosis, lack of sweating, and apparent enophthalmos.
Why apparent enophthalmos?
Well, because it's not actually sunken, but because you lose the sympathetic innervation to the inferior tarsal muscle, the lower lid rides up while the upper lid droops.
Ah, so the palpebral fissure narrows.
Exactly. It creates the illusion that the eye has moved back into the orbit.
Okay, classification done. Now the patient is in the chair. You've taken a solid history, checking duration, variability. But now you need to touch the patient.
Hmm.
What are the non-negotiable clinical tests?
The absolute safety check is Bell's phenomenon.
Yeah.
You hold the upper lid open and ask the patient to try and close their eyes gently. The eye should roll upward.
And if it doesn't?
If they lack a Bell's phenomenon and you perform ptosis surgery, you are exposing the cornea during sleep. The risk of exposure keratopathy is massive. It's a hard surgical red light.
Speaking of corneal risk, we definitely need to talk about the tear film.
Mandatory. You do a Schirmer's test. If you get less than 5 millimeters of wetting in 5 minutes, that's a dry eye.
And if you lift the lid on a dry eye, you're creating a problem you simply can't fix.
Precisely. You also check tear breakup time with fluorescein. You really want stability for about 20 seconds.
Now, we get the ruler out. We need strict numbers for the surgical algorithm. What are we measuring?
2 numbers dictate your entire surgical plan. First, the MRD margin reflex distance. That's the distance from the corneal light reflex to the central upper lid margin. Second, and most importantly, levator function.
There's a trick to measuring levator function correctly, though, isn't there?
You absolutely must fix the brow. Place your thumb firmly over the brow to paralyze the frontalis muscle.
Because patients unconsciously use their forehead to lift their lids.
Exactly. You need to isolate the levator. So you measure the excursion from full down gaze to full up gaze.
There are 2 specialized tests mentioned in the notes, the phenylephrine test and the fatigue test. When do you pull these out of your bag?
The phenylephrine test is for the perfectionist. It's for mild sputosis, so less than 2 millimeters. You put in phenylephrine drops, which stimulate Miller's muscle. If the lid pops up to a perfect position after 5 minutes, you know that just tightening Miller's muscle surgically is going to work.
And the fatigue test.
That is your screen for myasthenia gravis. Make them look up in sustained up gaze for 30 seconds to a minute. If the lid starts to drift down while they're trying to look up, that's positive for fatigue.
And you don't operate on that?
No, you send them straight to neurology.
Okay, this next part is the core of the revision, the surgical algorithm. This is the decision tree. It all depends on 2 variables. How good is the levator function and how bad is the ptosis? Let's walk through the hierarchy.
Let's assume the patient is cleared for surgery. Scenario 1. The levator is strong. Function is greater than 10 millimeters, but the ptosis is mild, just a millimeter or 2.
What's the play?
This is where that phenylephrine test comes in. You do a Miller's muscle shortening. The classic technique is the Fastenal Servat. You aren't touching the skin at all. You go from the inside, clamp the conjunctiva, Miller's, and the top of the tarsus, and you resect it. No external scar.
Nice. Scenario 2. Levator is still good, over 10 millimeters, but the ptosis is moderate. Let's say 3 or 4 millimeters of droop. Miller's isn't going to be enough here.
Correct. Now you need the workhorse procedure, which is the levator aponeurosis repair. You can do this via an anterior skin incision or a posterior approach.
And the huge advantage of the anterior approach is that you can do it under local anesthesia, right?
Yes, you can sit the patient up on the table, have them open their eyes, and actually adjust the height in real time.
Brilliant. Scenario 3. The levator is struggling, function is moderate, say between 4 and 10 millimeters.
You can't just repair the tendon anymore. You need to shorten the muscle. This is a levator resection. The worse the function, the more you cut. You use Beard's algorithm to calculate the millimeters of resection. It's usually anywhere from 10 to over 20 millimeters of muscle.
Got it. Final one, scenario 4. The levator is completely dead. Function is poor, less than 4 millimeters.
If the engine is broken, you need a tow truck. You do a brow suspension. You bypass the levator entirely and connect the eyelid to the frontalis muscle using a sling. When they raise their eyebrows, the lid goes up.
And there is a critical age distinction here regarding the material for the sling.
Yes, very important. If the patient is a child under 4 years old, their leg isn't big enough to harvest tissue. You use a synthetic material, like a silicone rod. This is Fox's method.
And if they're older?
If they're older than 4, the gold standard is autogenous fascia lata, tissue from their own thigh. That's Crawford's method. It lasts much longer and has less risk of infection or rejection.
Perfect. That is the upper lid sorted. Let's look down. Etropion.
Definition. The eyelid margin turns outward, away from the globe.
The problem here isn't just cosmetic, it's the vicious circle, right?
Exactly. The lid turns out, the punctum pulls away from the tear lake, so you get tearing or epiphora.
Yeah.
The patient wipes the tears, which pulls the lid down even further.
And then the conjunctiva dries out.
Right. It dries out, keratinizes, and scars, which pulls the lid out even more. You have to step in and break the cycle.
Classification mnemonic here is PICM.
PICM. Paralytic, so think facial nerve palsy. Involutional, which is aging and laxity.
Hmm.
Cicatricial, meaning scarring, pulling the skin down. And mechanical, like a heavy mass.
Assessment here is all about the snap. How do we quantify laxity?
Two main tests. First, the distraction test. Grab the lower lid and pull it away from the eyeball. If you can pull it out more than 10 millimeters, that is abnormal laxity.
And the second?
The snapback test. Pull it down and let go. It should snap back instantly against the globe. If it floats back slowly, or worse, if the patient has to physically blink to get it back in place, that's severe laxity.
You also have to check the anchors, the canthal tendons.
Correct. Look at the corners. If the lateral canthus is rounded instead of sharp, the lateral tendon is loose. If you pull the lid laterally and the punctum slides way over toward the pupil, the medial tendon is shot.
Let's talk repair. This is also hierarchical. Start with paralytic ectropion. The nerve is gone.
You always fix the medial side first. If the punctum isn't touching the eye, tears won't drain. You do a medial canthoplasty. If the tendon is really loose, you do a medial canthopexy to tighten it.
And if there's remaining ectropion?
If the lid is still sagging after that, you move to the outside and do a lateral canthal sling or Kuhn-Simonowski.
Let's get into the most common one, involutional ectropion. Just old-fashioned sagging.
The principle here is horizontal shortening. Think of it like tightening a belt. If the laxity is mostly medial, you cut out a diamond shape of tissue medially, the medial wedge or pentagon excision.
And if it's lateral?
You do a lateral wedge. But if the lateral canthal tendon itself is loose, which it honestly often is, you need a lateral canthal fling. You basically strip the tarsus, create a new tendon, and screw it or suture it to the orbital rim periosteum.
Makes sense. And if the patient has ectropion plus a bunch of extra baggy skin?
Then you combine techniques. That is the Kuhn-Simonowski procedure. It's a mouthful, but it's really just a wedge resection to tighten the lid, plus removing the excess skin under the lashes, the subciliary excision.
Moving to the opposite problem, entropion. The lid turns inward. The lashes rub the cornea. Extremely painful.
Classification mnemonic here is CIC. Cicatricial, scarring on the inside, pulling the lid in. Involutional, from aging. And congenital.
There is a tricky differential diagnosis for the congenital cases. The kid looks like they have entropion, but do they? Epibulferin versus true entropion.
This is a classic exam slide. In epibulferin, you have an extra roll of skin and muscle pushing the lashes up against the eye, but the eyelid margin itself is actually in the normal position.
Whereas in true entropion,
the actual tarsal plate and margin are fully rotated inward toward the eye.
And clinically, distinguishing cicatricial from involutional.
Just try to flip the lid out. If it's cicatricial, scar down from trachoma or a chemical burn, it will be stiff. You literally can't avert it. If it's involutional, it's floppy. It flips over easily.
Surgical management, go.
Cicatricial. The problem is a shortage of the back layer, the posterior lamella. You have to cut the scar and put in a graft, like mucous membrane or hard palate. Congenital. You usually excise a strip of skin and muscle and stitch the skin crease down to the tarsus to stop that override.
And involutional, this is the one every resident needs to know cold.
The gold standard is Quickert's procedure. It's a triple threat because involutional entropion has 3 distinct causes: horizontal laxity, retractor disinsertion, and overriding orbicularis muscle.
And Quickert's fixes all 3.
Exactly. You tighten the lid horizontally, you reattach the retractors, and you scar down the orbicularis so it stops rolling inward.
Ideally done in one sitting. Okay, we are entering the rapid-fire round. These are the quick definitions and procedural nuggets you need to snap out to pass. First up, lash abnormalities. Don't mix these up. Trichosis versus distichiasis.
Trichosis is acquired. Normal lashes growing from normal follicles, but they're pointing the wrong way, inward. Distichiasis is congenital, a mutant extra row of lashes growing directly out of the meibomian gland orifices.
Soft tissue conditions. Differentiate symbolferin and epicanthic folds.
Symbolferin is an adhesion, basically a bridge, between the eyelid conjunctiva and the eyeball conjunctiva. Think Stevens-Johnson syndrome or chemical burns. Epicanthic folds are vertical crescents of skin at the medial canthus, very common in Down syndrome or blepharophimosis syndrome.
If you have to surgically fix an epicanthic fold, what is the flap?
The Musside jumping man flap, or a YV plasty.
Tersorrhaphy, stitching the lids shut to protect the eye. Why do we use tubing or bolsters?
To stop the suture from acting like a cheese wire and slicing right through the skin, you use bolsters to distribute the tension safely.
Okay, final major topic. This is a terminology minefield. Globe removal. If you get these wrong, you sound dangerous. I'm going to give you the term, you give you the precise anatomical boundaries. First, evisceration.
You act like you're scooping out a boiled egg. You remove the cornea and the jelly, the intraocular contents, but you leave the shell, the sclera, and the muscles attached to it behind.
Second, enucleation.
You remove the whole marble, the entire globe and the sclera come out. You cut the optic nerve, but you leave the other soft tissues, the fat and muscles, in the orbit.
Third, exenteration.
The nuclear option, used for aggressive cancers. You remove everything, the globe, the lids, the muscles, the fat, the nerves, right down to the bone in the superior steel plane.
So zooming out a bit, what is the takeaway for revision strategy here?
Don't memorize lists. Memorize the decision trees. For ptosis, it's not just fixing the lid, it's balancing liveator function versus teratosis degree. For entropion, it's identifying the laxity as a medial or lateral. For entropion, it's distinguishing scar versus laxity. And here is a final provocative thought to leave you with. In practice, we often mentally categorize these surgeries as functional or cosmetic. Insurance companies certainly do. But consider the biology. In ptosis, the threat is visual field loss. It's a slow, distinct problem.
Yeah.
But in ectropion or entropion, the threat is corneal exposure or ulceration. That is an immediate organ-threatening problem.
Exactly. A droopy lid might easily wait 6 months. An entropion rubbing lashes on a cornea needs fixing this week. The functional label is broad, but the clinical urgency is totally different. Understanding that nuance, that triage, is what moves you from a junior resident to a consultant mindset.
That's a wrap for this revision deep dive.
If you want to know why we prefer anterior versus posterior approaches in liveator repair, or hear us break down a complex case of recurrent entropion where the algorithm just completely failed, you need to subscribe to Premium.
Don't forget to rate and follow. Good luck with the revision. We'll see you on the next deep dive.